So I think directly coming to the topic, majority of our patients are happy after a total hip. It's not like total knee, because total knee, I think almost 20% of our patients are unhappy, which is evidence-based medicine. Total hip, almost all of the patients are happy, excepting 2 to 5%. So to assess how to sort of go about when the patient is not happy and the patient, he or she, is complaining about the pain. So again, I reiterate, THR has been called as the operation of century. It has 95% survival, reaching to about 20 years post-surgery. Now, as we have seen in the previous lectures, there are a lot of permutations and combinations: cemented, uncemented stems, cemented, uncemented cups, dual mobility cups, various bearings. That's why, because of the variety of prosthesis and fixation modalities employed in the THR, evaluation of a patient with a painful hip arthroplasty can be really tricky. So identifying the source of pain in painful hip arthroplasty is extremely important, so that you can formulate your treatment and you can offer relief of pain to that particular patient. Again, the assessment and treatment of the patient is difficult, as always, he or she was promised to be pain-free following up that particular index operation, and unfortunately he is not. So let us come to the common causes of pain. I think in the decreasing order of importance, they are infection, fractures, greater trochanteric bursitis, ILIOPSOAS impingement, obviously a radiating pain, because majority of the elderly patients or middle-aged patients, they have degenerative spine disease, especially lumbar spine disease, and lumbar canal stenosis. Then limb-length discrepancy. I think Dr. Bhende is going to talk about that in detail. Then as the time goes by, after the index surgery, after about say 5 years or 7 years, aseptic loosening of the cup or stem or both, and unfortunately some of the patients, despite doing everything right, they land up with something called as a CRAPS, that is complex regional pain syndrome. So infection, I think all of us know, means if it happens immediately after the operation, the diagnosis is easy because there are symptoms and signs. There is a prolonged discharge from the operating wound. I personally have a very low threshold to open the hip, do a radical debridement, DAIR, means debridement, antibiotic, and retain the prosthesis if it is stable to begin with. There is a local rise of temperature and tenderness, elevated ESR and CRP. Hip movements are painful. That is the classical sign of a hip, sort of infected hip. Or if it becomes an acute hematogenous infection afterwards, like a delayed infection, then a well-functioning hip will suddenly become painful and there will be a decreased range of motion. That is pathognomic of a late onset infection. Obviously, the X-rays will show progression of the radiolucent lines around the prosthesis and the cement mantle. Sometimes you may see endosteal scalloping also. PET scans and WBC labeled nuclear scans are also of help. They show the increase in the uptake. The most important thing to do is to take the patient to the operation theater, paint and drape as if we are going to do a primary hip, and aspirate the hip joint and send it to a good laboratory. Now, there are a lot of values being quoted, but I think the general consensus is if you get a frank pus, obviously the diagnosis is straightforward. But even if the synovial fluid or the hip fluid shows the WBC count of about 1,600 or 1,800 per high power field, and if there is a neutrophil preponderance, that is more than 90% of the white cells are neutrophils, then most likely you are dealing with the infection. Second thing is fractures, more common on the femoral side, again more common with the uncemented stems because you need to really impact them, hammer them quite substantially. Vancouver classification, the A, G and AL, G is greater trochanter, L is lesser trochanter. So always look for the calcal fracture, means there are various very fantastic names being attributed to these calcar fractures, that is yawning of the calcar or mild fracture of the calcar, but I think be very careful, do a prophylactic wiring intraoperatively if you suspect a calcar fracture. Fractures of the calcar may be associated with sinking and loosening of the uncemented stem, especially in the elderly patients or the patients where the bone quality is not good. It can be easily diagnosed with plain X-ray and CT. Anterior thigh pain, especially on the lateral X-ray, if your tip of the prosthesis is touching the anterior cortex of the femur, as I think Dr. Kasodekar had said, that almost 10 to 15% of the patients with uncemented hip may have an anterior thigh pain. Again, it is seen in uncemented hips with improper placement in the lateral pain, causes tip of the stem touching the anterior cortex of the femur. Greater trochanteric bursitis, classically the patient has local pain and tenderness at the greater trochanteric area. Local ultrasound and MRI is the investigation of choice, usually responds to anti-inflammatory medicines and physiotherapy. ILIOPSOAS impingement, again, if your cup version is not correct, or if you are putting a too much larger jumbo cup, it may cause irritation of the ILIOPSOAS anteriorly, and typically the patient has a groin pain which sort of gets aggravated whenever there is a movement of the hip, especially the extension of the hip. Radiating pain from the spine, lot literature has been written recently about this. There will be symptoms of neurogenic claudication or radiculopathy. There will be a decrease in the sensation or hypoesthesia in the alpha S1 dermatome. Again, X-ray and MRI will pinch the diagnosis along with the classical signs and symptoms. Limb-length discrepancy, very hot topic, especially in North America. Fortunately, it's not that much litigious issue in our country, but seen in uncemented hip, for some reason, I think the uncemented hip replacement is more associated with the limb-length discrepancy than the cemented hip. Lengthening of the operated leg puts the ipsilateral abductor muscles under stretch, and they may produce pain, especially on ambulation. Aseptic loosening usually happens after 3 to 5 years or 7 to 10 years after the primary THR. Pain occurs mainly on ambulation and movements of the hip. Rest pain is usually absent if you are dealing with a painful hip because of the loosening or aseptic loosening. X-rays and CT scan are of use for this particular diagnosis. Complex regional pain syndrome is a diagnosis of exclusion. You rule out everything, and still if the patient is not happy or if he or she is having a pain, then probably you need to involve a pain consultant or your colleague who specializes in pain consultant, and maybe give something like a pregabalin or a duloxetine and various other things they employ. So what is the evidence-based medicine as we speak nowadays in the 21st century? A fantastic paper by Paprocki from Rush Medical Center, Chicago. They analyzed 201 painful hips. Now 26.4% of them, they had a periarticular pain because of trochanteric bursitis or ILIOPSOAS tendinitis and ischial tuberosity tendinitis. Heterotrophic ossification, not very common in our country. Then 24.4% of them, they had a projected pain coming from the spine. Wear was associated with the pain in about 20% of patients. Loosening accounted for almost 20% of patients with a painful hip. Material problems, metal on metal, I think that is also now out because nobody is using it. And trunionosis was responsible for almost 8.5% of the painful hips. Chronic infection, late onset infection was responsible for 3% of patients of pain in their series. Instability means subtle dislocation or instability was responsible for 1.5%, limb length discrepancy about 1.5%, and CRPS was almost about 1%. So again, I think this is a flow chart one can go about. As we can see, if you see a painful patient in the same paper, this flow chart is there. Painful hip, first rule out infection. If the infection is ruled out, then rule out the extraarticular causes which are coming from the spine. If that is also ruled out, then see for the periarticular causes like trochanteric bursitis, ILIOPSOAS impingement. If that is also ruled out, then see for the loosening or wear. If that is ruled out, then the lower possibilities like metal problems or metallosis and CRPS are there. So this is a sort of a decision tree which very nicely they have depicted in that particular paper. So I think I thank you for your attention.